Hello everybody. Today we are going to discuss about heat stroke. Heat stroke was first recognized by the Romans in 24 BC, but it took until 1946 for it to be shown that heat stroke could be to multi-organ damage with hemorrhage and the necrosis in the lung, heart, liver, kidney, brain, and gut, with 10 to 50% mortality. Heat stroke is the acute calamity caused due to abnormal high environmental temperature, which lead to elevated core body temperature of more than 40 degrees Celsius. This lead to the thermoregulatory dysfunction and exaggerated acute phase response, leading to the central nervous system and other organ damage. In some cases, survival may be associated with permanent neurological dysfunction. Global warming has taken an adverse effect on environmental temperature, causing undue abnormally high environmental temperature ranging from 45 degrees Celsius to as high as 50 degrees Celsius. Recently, phenomenally high temperature have been reported in many parts of the world, like Middle East, with temperature as high as 60 degrees Celsius in Kuwait, and also reported in various parts of the India. Impact of unbearably high temperature has led to the healthcare personnel to take organized of this medical emergency. Susceptible individual. Certain population is vulnerable to the heat stroke. These include elderly children, especially infant, pregnant female, patient on drugs such as diuretic, vasoconstrictors, beta blockers, anticholinergic, calcium channel blocker, thyroxine, benzodiazepine, antipsychotic drugs, and the neuroleptic medication, cocaine, and laxative. Patient admitted with the fever, chronic cardiac, respiratory, neurological illness, history of alcohol use, and presence of skin disease which impairs sweat. Individuals not physiologically adapted and are not systematically prepared for heat but exposed to unexpectedly to high ambient temperature are especially vulnerable. Summer tourists and those who had to walk on stand in the queen unexpectedly in the hot sun, inexperienced sportsmen participating in social sport event, especially in the hot weather. Now about pathophysiology. To understand the pathophysiology, it is essential to understand that thermoregulation is essentially the function of anterior hypothalamus, which maintain body temperature at approximately 37 degrees Celsius with responses mediated principally in the skin through sweating and vasodilation and through cardiovascular system, that is through gut vasoconstriction and increased cardiac output. It is exchanged with the environment in four ways, that is conduction, convection, radiation, evaporation, heat exhaustion occur when body's thermoregulatory responses are inadequate to preserve homeostasis. This can result from the extrinsic factor that make heat dissipation less efficient, such as extremes of temperature, physical effort, and environmental conditions. Excessive rise in the body temperature lead to the cellular toxicity, cellular damage, and eventually causing cellular death due to cessation of mitochondrial and enzymatic activity and instability of cellular membrane. There is also activation of the pro-inflammatory cytokine, which leads to the widespread cytotoxic effect on cellular metabolism, involving in almost all organ system of the body. Endothelial injury is also the integral part of the heat stroke. Inflammatory response is further aggravated due to gram-negative endoxemia due to bacterial translocation from the ischemic gut. These changes that take place activate the coagulation cascade, leading to the microvascular occlusion due to release microthrombi. This leads to the multi-organ dysfunction and failure. Dehydration and the renal compromise lead to the metabolic acidosis, which further worsen the situation. Diagnostic criteria for heat stroke: hyperpyrexia, that is core body temperature of more than 40 degrees Celsius, with alteration in the mental status. It may present as subtle and severe symptoms. Subtle severe symptoms include mild confusion, inappropriate behavior, and impaired judgment. Severe symptoms include delirium, encephalopathy, convulsion, and coma. In high ambient temperature, non-exertional heat stroke, it occurs in high ambient temperature. Exertional heat stroke, unaccustomed heavy exercise and the strenuous physical activity with or without high ambient temperature can lead to exertional heat stroke. Associated clinical findings include hot, dry skin, absence of sweating, and clinical signs of dehydration. Predisposing condition, these include individuals who are highly susceptible and individuals of extreme age and underlying chronic illness. Now, classification heat related illness are typically classified as heat cramps and heat syncope, heat exhaustion, and the heat stroke. So, heat cramp and heat syncope is characterized by dizziness, fainting, yawning, heavy sedation, muscle pain, stiffness, muscle cramp, and there is no impaired consciousness. Management provide patient with the first aid at site, monitor patient closely under a normal condition that is in cool environment. Adequate oral hydration with oral rehydration solution should be given. Stage 2 is the heat exhaustion that is characterized by the headache, vomiting, fatigue, sinking feeling, and impaired consciousness. Management transport patient to the medical institutional immediately if no improvement in the stage 1 occurs or condition worsen, along with the body temperature monitoring and management. Provide rest and adequate hydration intravenously, and if oral rehydration is insufficient. Stage 3 is heat stroke. It includes one of the following, that is CNS manifestation, hepatic renal dysfunction, DIC, and most severe of these three types. Management includes hospitalization with intensive care management, body temperature management, respiratory circulatory care, and DIC treatment. Differential diagnosis include intrinsic factors like central nervous system injury, hyperthyroidism, infection like, for example, malaria, meningitis, acute encephalitis, viral fever, neuroleptic malignant syndrome, pheochromocytoma, and Addison's crisis. Extrinsic factors like anticholinergic poisoning, alcohol intoxication, drug ingestion, anticholinergic poisoning, and drug ingestion. Management of the heat stroke, which is life threatening medical emergency that needs aggressive management. The patient needs on priority basis to be moved to the cooler area, assess airway, breathing, and circulation, and stabilize the patient. Send biochemical, hematological, and the investigation and coagulation profile. Do 12 lead ECG, ABG if required, and access central venous line. Start oxygen if hypoxemia occurs. Intubate patient if hypoxemia persists or impending respiratory failure occurs. Continue monitoring the hemodynamic and respiratory parameter while monitoring the core temperature. The mainstay in the treatment is rapid therapeutic cooling of victim at the rate of every 10 minutes by 1 degree till core temperature of 38 to 39 degree is reached. During this period, medical and nursing team should closely monitor the patient till target therapeutic range is reached. Later, the patient can be shifted to the air-conditioned environment. Once the core temperature is reached, check the temperature every hourly to prevent hypothermia or rebound hypothermia. Check for the differential diagnosis of hyperpyrexia and altered sensory. Please note there is no role of antipyretic medical agents and other drugs like dantrolium sodium in bringing down the temperature in patient with heat stroke. If there is high probability of underlying infection, empirical use of antibiotic is recommended. Therapeutic cooling of the patient is achieved by various means, and this include conductive cooling, that is external cooling and internal cooling. External cooling, here the skin should be massaged vigorously to counter cutaneous vasoconstriction by using ice cold pack, ice or ice block in the groin, axilla, and neck. Internal cooling, parenteral cooling is achieved using refrigerated intravenous fluid, that is normal saline, 5% dextrose or lactated Ringer solution. The cooled fluid may also be administered through nasogastric tube, urinary catheter into urinary bladder, and as rectal inhalation. Customized internal cooling devices are available to circulate cold fluid through central canal. Now, the evaporative cooling. This can be achieved either by draping the whole body with cold wet sheet. A resolving pedestal fan or heavy duty blower to drive the air over body to facilitate evaporation, or use of domestic air cooler can further help in cooling the body. Often combination of above method is required to achieve desired therapeutic effect. During this period, the combined effort of both medical and nursing team should be done. Management of complication. Proper fluid and the electrolyte balance should be maintained. All organ systems should be meticulously supported. Hypotension, if occurs, should be detected early and corrected with the IV fluid with central venous pressure monitor. Inotrope should be initiated at the earliest. Congestive heart failure and myocardial injury may occur but usually resolve on cooling. Use of antiarrhythmic drug and the drug treatment of CHF is rarely required. Respiratory complications are usually common. They range from the bronchospasm requiring bronchodilators and aspiration pneumonia, pulmonary hemorrhage to acute respiratory distress syndrome requiring ventilatory support. Renal replacement therapy should be offered in patients with acute renal tubular necrosis and monitor renal function. DIC should be treated with the fresh frozen plasma and platelet concentrate. If seizure develop, give midazolam to maximum dose of 4 mg. Repeat dose if required until neurological recovery. Cooling reduces the recurrence of seizure. IV sodium bicarbonate should be given for alkalinization of the urine to prevent acute kidney injury if rhabdomyolysis occurs. Hyperkalemia and myoglobulin precipitation in the renal tubule and metabolic acidosis are prevented by alkalinization of the urine. Hemodialysis may occasionally be. Thank you, guys.